Hello, and welcome to this video describing the recommended vaccinations for adults living with HIV. This video is presented as part of Learnings from the Blue Door, a 2-day educational event presented by the Blue Door Clinic partners in February and March 2021. We will focus today specifically on those vaccines that are covered in Ontario. And although many of the vaccines apply to children and adolescents, we will only focus on the adult vaccine schedule today. I want to open by thinking a little bit about why we vaccinate people with HIV. You have probably already guessed that if a person with HIV has a weakened immune system, they would be more susceptible to certain infections. Vaccines are one of the strongest, most effective tools we have to support people in preventing these types of complications. So a few tidbits to think about. In order for vaccines to work, they need to trigger an immune response. So we try and encourage vaccination earlier in the course of disease or when CD4 cell counts are high so that we can get the most out of these vaccines. Although we don't necessarily have to delay vaccinations just waiting for CD4 counts to recover, as we want to keep in mind exposure risk in the meantime. We tend to be cautious with live vaccines in people with HIV, as there is a small chance the vaccine could cause a variation of the disease. We'll talk about each live vaccine as we go through the schedule later. Vaccines can also trigger temporary blips in the viral load, so keep an eye out for that if you're doing blood tests. You may notice these small blips, but be reassured, and you can reassure your patients that these are not harmful. You can verify that the slight elevation in viral load has resolved by rechecking levels in 6 to 8 weeks. Okay, so let's jump right in with the routine and catch-up vaccinations. We'll start first with the influenza vaccine. Should be no surprise that this vaccine is both recommended and covered on an annual basis. One thing to remember is to avoid the live attenuated version of the flu vaccine, as there are many other non-live versions to choose from for your clients with HIV. We can also include tetanus, diphtheria, pertussis, and polio in this section. These are all covered for adults in Ontario, and this includes adults with HIV and newcomers to Canada. They can be offered as a catch-up schedule for people who do not have adequate immunization records. Next, we can move on to measles, mumps, and rubella. These are recommended for people with HIV, and we know from information in the era prior to effective antiretroviral therapy that measles was often much more severe in HIV-positive people who were immune compromised. So it is worth making sure that people are up to date with their MMR vaccines. One dose is covered routinely for susceptible adults in Ontario, and a second dose, followed 4 weeks later, is covered for certain higher risk groups. These include travelers, healthcare workers, post-secondary students, or those clients that are considered high risk in the clinician's judgment. One thing to note is that as a live vaccine, we do not administer MMR if the CD4 cell count is less than 200 or the CD4 percentage is less than 15%. The next vaccine on our list is the varicella or chickenpox vaccine. This is also recommended for people with HIV because varicella is often more severe in adults and, like measles, more severe still in adults who are immune compromised. It is covered in Ontario for susceptible adults, which includes adults with HIV. But as a live vaccine, it has the same CD4 restrictions about when it is safe to administer as the MMR vaccine that we just talked about. Let's now move on to additional vaccines that are indicated for people with HIV due to the higher risks associated with immune compromise. We'll start here with the pair of pneumonia vaccines that are active against pneumococcal pneumonia, specifically the 13-valent Prevnar vaccine and the 23-valent Pneumovax. It should come as no surprise that for years pneumonia was a significant challenge for people with HIV, especially before we had adequate medications to treat HIV. Keep in mind, though, that this particular vaccine series covers pneumococcal strains, which is not to be confused with pneumocystis strains, or what is known as PJP today, or PCP in the past. So, for the 13-valent Prevnar, 1 dose is covered for adults with HIV after the age of 50, and for Pneumovax, 2 doses are covered for adults with HIV given 5 years apart. I group these vaccines together because there are some considerations in the order in which we give these two vaccines. Ideally, we give Prevnar before Pneumovax, as there may be a primer effect if given in this order. The schedule would then be Prevnar followed 8 weeks later by Pneumovax, and then a Pneumovax booster 5 years after that. If, however, we give Pneumovax first, we have to wait a year before we can give the Prevnar. The next vaccine we will cover is the Haemophilus influenzae type B, or HIB, vaccine. Although it is covered in Ontario, it is not actually routinely given. Epidemiology of this disease in Canada does not really support routine vaccination of HIB for people with HIV. In the last 5 years, there have been less than 10 cases per year in Canada for this disease. There are higher rates of other strains of Haemophilus, but there are no vaccines available for those currently. Moving on to the Hepatitis A vaccine, which is recommended for HIV-positive adults. Some guidelines suggest all people with HIV should get this vaccine because of the overlap between higher risk groups and HIV risk, and also because HIV can prolong Hep A infection. While other guidelines suggest HIV-positive people with additional risk factors should get this vaccine. In Ontario, the Hep A vaccine is covered for susceptible adults who meet the following criteria: if they are gay, bisexual, or other men who have sex with men, or if they are people who use injection drugs, or people who have liver disease. The next vaccine on our list is the Hepatitis B vaccine. And first off, why is it important to give the Hep B vaccine? Hep B shares many routes of transmission with HIV, for example, sexual exposure, shared drug use equipment, vertical transmission. We also know that HIV can reduce the chances of clearing Hep B, which is then more likely to lead to a chronic hepatitis B infection. If a person does become co-infected with Hep B and HIV, this can also increase the complications associated with chronic hepatitis B, including a greater risk of developing cirrhosis. Co-infection with these two viruses also complicates treatment options, as some drugs that we use to treat HIV are also used to treat hepatitis B, so we have to keep that in mind when prescribing treatment. The hepatitis B vaccine is covered in Ontario. We recommend 3 doses at 0, 1, and 6 months. Interestingly, we also recommend a 40 microgram dose at each immunization. So for the Engerix version, this is a double dose. And for the Recombavax version, there is a specific dialysis formulation that is a quadruple dose. This high dose of vaccine is recommended in order to try and increase vaccine efficacy. For Hep B, you can check the titers 1 month after completing the series, and if there is no immune response, you can repeat the series once more, and then check the titers again a month after it's complete. If the client does not mount an immune response, they are deemed a non-responder and should be considered susceptible to Hep B infection and assessed for infection if symptoms or risk factors are present. Once a client has confirmed immunity from hepatitis B, some practitioners consider serologic testing periodically and offering booster doses in case immunity wanes over time. The meningococcal vaccines are also on the list of recommended vaccines for HIV-positive adults. One type of vaccine covers subgroups A, C, Y, and W, and others cover subgroup B. We know that HIV increases the risk of invasive meningococcal disease, and that there is an overlap in populations affected by both HIV and infectious meningitis. For example, there have been outbreaks noted in gay, bisexual, and other men who have sex with men. This vaccine is covered for adults with HIV, and it's recommended to give 2 doses 8 weeks apart, and then a booster dose every 5 years. You do that until the age of 55. Guidelines also recommend giving 1 additional lifetime booster after the age of 55. However, the MenC-ACYW135 vaccines are not authorized for use in people over the age of 55. But based on some evidence and expert opinion, their use is considered appropriate and safe. Of the 2 versions of this vaccine, Menveo was studied and deemed to be safe, while Menactra itself has not been studied in this age group. The 4C-Men-B vaccine covers the B strain, and you can consider this in HIV-positive adults, but it's not covered in Ontario, and it is not authorized in patients over the age of 26. Speaking of the age of 26, we will now move on to the human papillomavirus and the vaccine. We do recommend giving people with HIV the HPV vaccine because HIV-positive people have higher rates of HPV-related disease, like anal cancer or cervical cancer. This vaccine is covered in high school for teenagers, and that started in 2007 for girls and 2016 for boys in Ontario. Adult coverage is only available in Ontario for gay, bisexual, and other men who have sex with men who are aged 26 and younger. For adults, we recommend 3 doses at 0, 2, and 6 months, and although it's covered for MSM under the age of 27, it is approved for use in males up to the age of 26 and females up to the age of 45. We know that there's greater benefit from this vaccine if there's less than 5 lifetime sexual partners, but it is still considered safe to give at older ages, and some clinicians consider giving it to people with ongoing exposure risks, trying to balance the efficacy of the vaccine against risks that clients may have for HPV. The last vaccine to review is the herpes zoster or shingles vaccine. Adults with HIV have a greater risk of shingles than those without HIV. This vaccine is recommended starting at age 50. In Ontario, though, it is covered between the age of 65 and 70. There are 2 versions available for this vaccine, and both are covered in Ontario, but because Zostavax is a live attenuated version, we avoid its use in people with HIV and prefer the Shingrix version, which is a non-live recombinant vaccine. So that takes us through the individual vaccine schedule. I thought we could wrap up with a review of a few key messages. Remember to give vaccines earlier in the course of disease where possible, specifically before significant declines in CD4 cell count. Avoid live vaccines in people with HIV if the CD4 count is below 200. Vaccines can trigger a temporary increase in viral load, but this is not harmful and usually resolves in 6 to 8 weeks. There are some differences between what's recommended and what's covered in Ontario, so consider other ways of funding vaccines, including private coverage, paying out of pocket, or pharmaceutical patient assistance programs. And although beyond the scope of this video, immune compromise, including immune compromise from HIV, may mean a client will need immune globulin in addition to vaccination for post-exposure management for some diseases. For example, in tetanus post-exposure management, you might consider immune globulin for HIV-positive patients. For more information on vaccines in people with HIV, you can review the Ontario Ministry of Health's publicly funded immunization schedule, which was updated in January of 2021, the Public Health Agency of Canada's Canadian Immunization Guide, which is updated regularly online, as well as the U.S. Department of Health and Human Services guidelines for the use of antiretroviral agents in adults and adolescents with HIV. Thank you, and happy vaccinating!